Here is the outline of our presentation. Begin with the signalment. The patient name is Namtao, a female crossbreed dairy cow. Namtao is 9 months old and her body weight is 207 kilograms. The chief complaint from the owner is that the cow experienced 2 episodes of seizure and she currently appears depressed. From the additional history, the cow first showed depressed. The owner then called a veterinarian who administered an injection. Although the owner could not identify the drug, after that the cow had her first seizure on August 8th. 2 days later, she had another seizure. Both seizures lasted about 5 minutes. Following the episodes, the cow became depressed and stopped ruminating. The owner again called the veterinarian to administer another injection, with the drug also unknown. After the injection, the cow's condition improved. She resumed ruminating but remained depressed. That is why the owner asked us to check on her, and we visit the farm on August 20. The seizures were described as follows. The cow began with one limb extension and rigidity while standing, then sat down in a dog-sitting posture and collapsed into lateral recumbency with continued limb extension and rigidity. Vocalization was also heard during the seizures. For the farm history, it is important to note that 2 years ago, another cow aged around 8 to 9 months also showed seizure with padding movements and died suddenly. Now regarding feeding management, this cow is fed Napier grass 1 to 2 kilograms per cow per meal, twice daily in the morning and evening. She also received 1 to 2 kilograms per cow per meal of concentrate feed with 12% crude protein, once daily in the morning along with rice straw 1 kilogram per cow per meal in the evening. Additionally, she is given milk 2 kilograms with water 8 kilograms in the morning along with a mineral block. Water is provided at the bottom from a groundwater source. As for preventive care, she received vaccination against FMD and lumpy skin disease at 4 months of age. Deworming with albendazole was done only once at 2 months of age. This deworming program is used throughout the herd. Her clinical signs reported by the owner were decreased appetite with normal drinking and normal defecation. On physical examination, every parameter is normal. To summarize the findings, the specific problem list is seizures.
Name the assessment of seizure divided into 2 courses. There are extracranial and intracranial. The underlying cause will be investigated. Extracranial lesion can result from exogenous toxins such as strychnine, organophosphate, detoxicity, Clostridium tetani, Clostridium perfringens type C and D. Endogenous toxins such as hepatic encephalopathy and renal encephalopathy, vascular perfusion disturbance, metabolic system disorder. Intracranial lesion can result from primary abnormality in the brain itself, which may be genetic, idiopathic, or acquired. Secondary abnormality which result from the other cause such as infection, inflammation, or immune-mediated disease. Strychnine, organophosphate, Clostridium tetani, and Clostridium perfringens type C and D can be ruled out by history showing no glycine in area with exposure to these toxins. Absence of clinical signs consistent with this cause, unremarkable physical examination based on no wound and no ingestion of cassava, which blood trace can be confirmed. Vascular perfusion disturbance can be ruled out based on physical examination, showing no abnormality in blood perfusion. Primary seizure can be ruled out from the history taking, showing no trauma and cow didn't show seizure signs since birth. Secondary seizure related to previously mentioned condition can be ruled out based on clinical signs and history, showing no ingestion of vermin feed. The remaining possible require further diagnostic evaluation. Initial plan are complete blood count, serum biochemistry, physical examination, and disease lab result and reward assessment. Begin with physical examination, reduce Songchai type X at 1000 x per gram, Molesia benedeni X at 100 x per gram, and Imalia oocyst at 34,000 oocysts per gram. First is complete blood count with the leukopenia show no abnormal parameter profile. Red blood cell show MCV is low, but RBC count, hemoglobin, and hematocrit are normal. Therefore, the low MCV is not significant. Platelets show thrombocytosis with increased platelets on smear, which can occur in both primary and secondary cause. First, primary thrombocytopenia is unlikely because it's rarely seen in cattle, and secondary cause related to anemia can be ruled out because RBC count, hemoglobin, and hematocrit are normal, and there are no signs of hemolysis or hemorrhage. Additional hyperfibrinogenemia was observed with this consequent with acute inflammation.
The parts of serum biochemistry reveal low BUN with normal creatinine, which can result from low protein intake either due to quality or quantity, or from impaired urea synthesis. In this case, low protein intake due to quality was ruled out based on history, as the heifer was provided with concentrate feed. Liver disease was also ruled out, as CST was low and GT remained within normal range. Regarding hypocalcemia, this condition can arise from decreased protein binding, parathyroid hormone abnormalities, decreased calcium absorption, or excessive calcium loss. Decreased protein binding was ruled out because the cow did not have hypoalbuminemia. Resistant parathyroid hormone due to hypomagnesemia was ruled out because magnesium levels were low but still within the normal range. Renal disease caused parathyroid hormone resistance or excessive calcium loss was ruled out because BUN was low but creatinine was normal. High oxalate toxin exposure was ruled out based on history, as the raw fed provided was Napier grass. And milk fever was ruled out because the cow was young and had not yet been bred. Low normal magnesium level can result from decreased protein binding, reduced intake, or excessive magnesium loss. Excessive loss due to upper gastrointestinal obstruction was ruled out, as there was no clinical sign of upper GI obstruction. In the revised assessment of seizure, exogenous toxin, including lead, were ruled out, as there was no increase in nucleated red blood cell or basophilic stippling in red blood cell. Another toxins were ruled out based on blood work results. Endogenous toxins were also ruled out. Hepatic encephalopathy was ruled out, as AST was low and GAT was normal. And renal encephalopathy was ruled out, as BUN was low but creatinine was normal. Metabolic causes such as hyperosmolality were ruled out based on normal hydration status and BCCOE. Ultimately, serum biochemistry revealed hypocalcemia, which is considered the most likely trigger for the seizure in this case. The next part will be the revised problem list. Firstly, seizure secondary to hypercalcemia and low normal magnesium level. Thrombocytosis, increased platelet count on smear, and hyperfibrinogenemia, likely secondary to the gastrointestinal parasitic infestation in this cow. Low BUN with normal creatinine, hypocalcemia, and low normal magnesium level can result from nutritional imbalance, induced seizure, and gastrointestinal parasitic infestation. And positive gastrointestinal parasitic ACE confirming gastrointestinal parasitic infestation. Therefore, the tentative diagnosis in this case is hypocalcemia-induced seizure with concurrent gastrointestinal parasitic infestation.
As for the treatment and management, on the 20th of August, we prescribed vitamin B complex at a dose of 1 ml per 5 to 10 kg, administered intramuscularly once. Ramical premix administered 1 to 2 tablespoons per cow by topping on feed until changed into proper feeding program. On 23 of August, we prescribed albendazole at a dose of 10 mg per kilogram, administered orally once. Protazolim a dose of 15 mg per kilogram, administered orally once, and let the owner continue giving Ramical premix. Also, we recommend the owner to cut the grass in the late morning, at least 1 palm height above the ground, to reduce contamination with parasitic egg. As for the follow-up on 3rd of September, the cow has no seizure, normal appetite, and defecations. Still, we recommend the owner to continue monitoring clinical signs. For further plan, we will do as follows. The first one is to recheck the parasitic infestation.
The second one is recheck blood examination, especially after completing the 3 week of adjusted diet. The third one is recommend the owner to change feeding program, as history taking revealed that the current feeding program is inadequate for growing in both quantity and quality of roughage and concentrate. The fourth one is advise the owner to deworm the cattle regularly according to an age-appropriate deworming program as follows. The fifth one is give coccidiosis prophylaxis throughout the herd, since the lab result of this cow shows myriad infestations. So the to be discussed. The first study was a retrospective analysis of cattle admitted to the University of Turin, Italy, between 2002 and 2014. A total of 43 cattle were included in this study. The animal range in age from 10 days to 5 years. The result that they found is that approximately 70% of seizure cases were due to metabolic cause, include hypocalcemia, hypomagnesemia, or a combination of both. The remaining 30% were attributed to a structural cause diagnosed as cerebrocortical necrosis, infection, or lead poisoning. The outcome after treatment are 33 cattle survived, in which 30 with reactive seizure diagnosed and 3 with cerebrocortical necrosis. In conclusion, seizure in beef cattle are most commonly caused by treatable metabolic disorder. Prompt diagnosis significantly improved the survival outcome. The second study was a case report of a 6-month-old female hostile Friesian calf with a history of recurrent seizures since birth, despite both parents being clinically normal. At presentation to the clinic for ruminant, University of Bologna, Italy, the calf underwent a neurological examination, CBC, serum biochemistry, venous blood gas, urine analysis, cerebrospinal fluid analysis, and serology for Sigma-Lemberg virus, Neospora caninum, blue tongue virus, and toxoplasma gondii. The only abnormal finding was an elevated CK level, and all other results were within normal range. During hospitalizations, the calf experienced seizure 1 to 4 times per week and never more than once per day. Episodes were accompanied by the collision with surrounding objects, resulting in additional injuries, so the clinical condition progressively deteriorated, and euthanasia was ultimately performed to prevent further suffering of the animal. Histopathology revealed lesion compatible with genetic, degenerative, and metabolic disorder. So based on this finding, the investigator hypothesized a genetic etiology. So the DNA was extracted from blood sample and subjected to the whole genome sequencing, which identified the DYRK1B gene haploinsufficiency. So this case represents the first report linking DYRK1B haploinsufficiency to seizure in cattle, suggesting that this gene may act as a significant predisposing genetic factor in bovine seizure. Here's our reference, and here are our group members. Thank you all, Professor, for your guidance and support throughout our clinical rotation in the past 3 weeks. Thank you, our audience, for your attention. If you have any questions, please feel free to ask.